And I welcome everybody to today's webinar. Thank you for coming to our topic on thalassemia in the emergency room, key information for medical care providers. This is something that the Cooley's Anemia Foundation is presenting as part of a grant that we have, or a cooperative agreement that we have with HRSA. And so I'm going to read our disclaimer there, which is: this program is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $75,000 with 0% financed with non-governmental sources. And the contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by, HRSA, HHS, or the U.S. government. For more information, please visit hrsa.gov. So today, Tom Coates is going to be presenting on thalassemia in the emergency room. And what we will ask everyone to do, first off, when I finish talking, I'm going to mute everyone, and then ask Tom, you'll need to probably unmute yourself, therefore. But I'm going to mute everyone so that there won't be distracting noises, although it looks like everybody's already muted. I might not have to. And what we will ask is, as we go along, please save your questions till after Tom has presented. If you want, you can go ahead and type them into the chat box if you would like, or you can just save them toward the end, and then we'll ask people with questions to raise their hands. And we're thrilled to be presenting this today, and we're absolutely thrilled to have Tom Coates here as our presenter. For those of you that may not know Tom, he is the section head of hematology, the attending physician in hematology oncology and blood and marrow transplantation, and investigator in hematology oncology at Children's Hospital Los Angeles, and professor of pediatrics and pathology at Keck School of Medicine at USC. So Tom, we will take things away and let you speak now.
All right, let me see if this. All right, is that sharing? Whoops.
Not yet.
How about now?
Now I believe it is. Yes.
Okay. All right, great. So, Craig, thanks, and it's my pleasure to present on this topic. Hopefully, I'll hit the high points here. My assumption is that many of the people listening are emergency room personnel, not necessarily hematologists, although I see a lot of hematologists named in the list here. So I will start with a little introduction on thalassemia before we get into how thalassemia can present in an emergency. So a couple disclosures that don't really totally apply. So about 7% of the world's population has a significant hemoglobin variant. And so there's about 350 kids born every year that have a severe inherited hemoglobin disorder. And about 3% of the world population is heterozygous for beta thalassemia. So this problem is more common than you might think it is in the general population. The highest prevalence is, in Southeast Asia and China, Indonesia, and the Mediterranean areas, but about 75% of the immigrants to the United States are from areas where thalassemia is prevalent. So it's not unlikely at all that you would see a thalassemia patient in the emergency room. So there's well over 1,000 mutations in the hemoglobin gene, and thalassemia is due to mutations that decrease the production of primarily alpha or beta chains. And so 2 alpha chains and 2 beta chains is normal hemoglobin A1, and 2 alpha chains and 2 delta chains is A2, and 2 alpha chains and 2 gamma chains is hemoglobin F. And so in the thalassemia syndromes, the hemoglobin that is made is actually, normal in structure. You just can't make enough of it. So because of the decreased production of one of the component chains. When we talk about this, you'll hear us talk about beta 0 thal, beta plus thal. If the mutation that you have allows no production of any beta chain at all, then we call that beta 0. If there's some production, we call it beta plus. And so when you do electrophoresis, if you see a little bit of hemoglobin A1, even 1%, we refer that to as beta plus thalassemia. Now, you're not doing this kind of thing in the emergency room, but just to give you a little bit of background. Structural mutations in the globin genes itself result in abnormal hemoglobins, like hemoglobin S or sickle cell disease, which you're all aware of. And in general, with these diseases, their ability to make the abnormal globin is normal. They make tons, unfortunately, tons of abnormal sickle hemoglobin, for example. And then there are combinations of mutations, of course, which can occur. And most commonly, we think of sickle trait AS, which normally you would call the sickle cell trait. But if you have a beta 0 thalassemic mutation on the hemoglobin A side, you don't make any hemoglobin A. That patient has only S and is basically the same as SS, sickle cell disease. So again, thalassemia is a quantitative inability to make beta chains, which is mainly what we'll be talking about, also to make alpha chains. So we classify the thalassemias roughly, as I've indicated here. Thalassemia minor, that word you've heard, refers to the thalassemia trait. It's a normal hemoglobin A and a beta thal mutation. These patients, and this is an important point, in hemoglobin, thalassemia minor or thal trait, the hemoglobin is greater than 10. If you think they have thal trait and the hemoglobin is less than 10, you need to look for something else going on. This is a sort of a major point. These patients do not have any clinical symptomatology at all, other than their CBC looks like iron deficiency. Thalassemia intermedia refers to any combination of thalassemia mutations that allows the patient to make more than 6.5 grams of hemoglobin without transfusion. And again, there's lots of combinations, literally thousands of possibilities here. And so this diagnosis, thalassemia, refers to the clinical phenotype, the level of hemoglobin that results. And some of these patients don't require transfusions, or so-called non-transfusion dependent thalassemia patients, and others require transfusion. And I don't have time to talk about this in the emergency room. How you make this decision is really a matter of the biology of the thalassemia, and also who the particular hematologist is that's managing the patient. They often have some splenomegaly. And of course, thalassemia major means you have severe anemia. These patients are always transfusion dependent. And here are the results of having thalassemia or thal major. You can have a number of complications that you may see in the ER for treatment. And we'll talk about these in more detail in subsequent slides. So the anemia in thalassemia really is multifactorial. And as we just talked about, the inability to make beta chains is really the key issue. But this imbalance in alpha and beta chains and the drive, the anemic drive to increase bone marrow activity, but the inability to make hemoglobin causes marrow toxicity and really results in what's called ineffective erythropoiesis. And so normally immature red blood cells mature. There's a smaller number of red cell precursors that mature and ultimately to form mature red cells. But in thalassemia, you have a huge drive to correct the anemia, but there's maturation arrest which occurs because of the toxicity we're talking about here, so that there are no mature red cells. And so the bone marrow cavity fills up with tons and tons of immature red blood cells. I'll show you a picture of that in a minute. This results in some of the complications that you'll have to address. Also, as an effect of the alpha beta chain mismatch in thalassemia, the red cell survival is shortened. And in the emergency room, this is going to present as anemia from marrow suppression. So both transfusion and dependent and non-transfusion dependent patients can become quite anemic, actually, in the face of viral infections and other things that they may encounter. And since they're not able to make red cells and the red cells don't last very long, a transient viral infection can cause a non-transfusion dependent thalassemia hemoglobin level to drop from, say, 8 down to 4 even over the period of a week or two. Normal people have a red cell survival. Well, 50% of the red cells that I make today are present still 56 days from now. So half-life of about 56 days. This is not the case with thalassemia patients. The half-life is much shorter. So with any kind of viral infection, if your marrow shuts off for a week, for me, my hemoglobin drops half of a gram in a week. But for these patients, their hemoglobin can drop a lot. This is a consequence of the shortened red cell survival and affected erythropoiesis. Now, this marrow cavity expansion, you can see here on the skull X-ray. Here's the normal skull, and you see all of this increased bone marrow expansion of the bone marrow cavity because of this. This is happening all over the place, and in increasing the marrow cavity and decreasing the cortical thickness of bones in the arms and legs, as well as what we see here in the skull. So you see bony deformities from marrow expansion, but more importantly, you see a severe osteoporosis, and this presents as bone pain and fracture, both from osteoporosis, and this is something that you may very well be addressing in the emergency room. Similarly, these patients are trying to make blood like crazy, so they make blood outside of the bone marrow cavity and forms tumors along the spine. They're not malignant. They are tumors containing bone marrow, and these can press on nerve roots and cause a radicular pain from nerve root compression. So again, something we shouldn't be saying if the patients are being properly managed, but nonetheless, especially in older patients or ones that aren't being properly transfused, this can be an issue. Of course, iron overload, this occurs both in patients who are being transfused and those who are not. Patients with ineffective erythropoiesis and hemoglobin of 9 can have significant iron overload, especially when as they get much older. Transfusion-dependent patients have a lot of iron overload, and they can have severe cardiac complications, and we'll again talk more about this, but heart failure, arrhythmia, diabetes. Adrenal insufficiency is something you really need to think about. Some papers suggest as much as 30% of patients with transfusion-dependent thalassemia have at least some degree of adrenal insufficiency. And this can be important in automobile accidents or bone fractures or any other kind of serious event that you may encounter in an emergency room setting. So you should always have that in mind with an iron overload patient. It could be adrenal insufficiency. So this chronic anemia causes a lot of the problems in thalassemia. And if we look at the relationship of probability of having morbidities, and I've listed those over here, if the hemoglobin is chronically over 10, and or less than 10, for decades, you have a high probability of having multiple morbidities, all of which can present in the ER, as I've talked about. We'll talk about it a little bit more. So chronic undertransfusion is the cause of a lot of these problems. And of course, that's not something that you're going to fix in the emergency room. You're just going to have to deal with the consequences. So if we look at the morbidity in thalassemia, in the 1960s, the median survival was about 5 years. And then they figured if we transfuse them, maybe that'll help. And you can see that by the 1970s, the median survival came up to around 16 or 17 years. but now the patients are dying from iron overload. Subsequently, we've learned how to manage that, and the prognosis has gotten a lot better. And so nowadays, patients' overall morbidity or survival is probably very close to that of the normal population. If you look at non-transfusion dependent thalassemia patients, this is a retrospective review of a couple of thousand patients that came out a year or so ago by Shalom and colleagues. You can see that their median survival is pretty good. It's in the 50s or 60s. But in the subset of those patients who were put on transfusions, their survival is even better. So even today, with current management, suppressing bone marrow activity has a significant survival advantage. And what is very interesting in this population of patients is that 12% of these patients have died because of non-iron related cardiomyopathy. So chronic anemia leads to myocardial fibrosis and leads to left ventricular failure, even if the heart isn't loaded with iron. So this is sort of a new concept on the block and something that we need to really be thinking about when these patients come into the ER. Again, if we look at this cutoff point of 10 grams, if their standard hemoglobin concentrations are less than 10 grams, the probability of them having multiple complications is much higher than if their hemoglobin is regularly over 10 grams. And the other point that I think is really important, this is an interesting data set that from Italy from 2010, 2011, looking at patients that are managed at specialized centers in Italy versus ones that are where there's not a specialized focus on thalassemia. And I assumed when I read this paper that everybody in Italy, of course, this is the center of thalassemia, Italy and Greece, right? I thought all doctors knew how to treat it, thalassemia, but this isn't the case. You can see the survival in the small centers in Italy is still less than 20 years and much better in major centers. And so the take-home message here is if you're in a small emergency room and the patients are being managed by practice that only has a couple of thalassemia patients, you really need to be connected to a center that's managing a lot more patients. And Cooley's anemia is really terrific in helping out with this. And I know all of the directors of the centers, some of whom are online today, will be delighted to connect and to work with smaller institutions in managing these patients, because you can make a huge difference in the overall outcome of patients with the kind of assistance that we can do by email. So this is a 32-year-old, this is an actual case that we saw here, a 32-year-old male who presented to Children's in 2017 with frank heart failure. Couldn't lay flat, couldn't walk for 20 feet, was in bad shape. He, in fact, had driven here several hundred miles from another state when he was in trouble because he couldn't get in an airplane. He knew better than to do that because he was so short of breath. And we admitted him to a local adult hospital under the care of one of our adult hematology colleagues in Los Angeles. And the initial cardiology consult was recommended heart transplant. His ejection fraction was 16% by echo, which is terrible. His cardiac T2 star was 6 milliseconds, so he had tons of iron in his heart. A normal T2 star is greater than 30, meaning no pathologic iron in the heart. And anything less than 8 milliseconds indicates severe cardiac iron load. So he was started on continuous chelation, and within a week or two, he was symptomatically dramatically improved. And within 3 weeks, he was discharged on 3 iron chelator. 3 months later, we saw him in clinic at the Children's Hospital. His ejection fraction was now 70%, totally normal, but his cardiac iron was still horrible, tons of iron. So making the point that the constant presence of circulating chelators, getting rid of the circulating toxic form of iron, functionally is very beneficial. And I'm going to bring this up when we talk about the ER management of these patients. The other point is tons of iron in the heart and dysfunction corrected. So MRI is measuring ferric iron, the non-toxic form of iron. Your body takes toxic ferrous iron and converts it to ferric iron to detoxify. So we're talking about heart failure and arrhythmias. Unfortunately, these are relatively uncommon in centers where patients are being monitored by thalassemiologists, if you will, in major thalassemia centers. But it is the most common cause of death worldwide in thalassemia still is heart failure from iron overload. And it is almost 100% reversible if the heart failure is secondary to iron overload itself. And if you get the patient within 3 or 4 days of when they're going to die, you need a little bit of time to turn these things around. Normally, this isn't something you're going to see in 10-year-old kids. It takes 10 to 15 or 20 years to get in that much trouble. So it's a problem of a little bit older patients. So circulating ferrous iron enters through ion channels, through L-type calcium channels in the heart. And the red dots you see here in this picture indicate ferrous iron that are entering through calcium channels, and they really mess up the excitation contraction coupling in the heart. And this is one of the major contributors to the arrhythmias that can be seen in ventricular tachyarrhythmias, as well as heart failure. Also, the mitochondrial iron loading is tremendous, and that causes a cardiac dysfunction and left ventricular dysfunction, as we saw in the case that I presented. So the acute management is to start chelation right away. And so when these patients come in the emergency room, it's not, oh, let's get them on a chelator in a week or two from now because we need to get them unloaded. There are acute effects of starting continuous infusion. Desferal will give you the doses in the next slide that can stop, especially the arrhythmias, even as quickly as in 30 to 60 minutes in some cases with rhythm disturbances. So this is part of the acute management. And you may see a functional improvement relatively quickly, but removing iron from the heart takes, the half-life removal of iron from the heart is about 13 months. So it takes a while to get through all the stored iron out. So again, we start chelation immediately with continuous infusion of desferal. This is the dose, and you don't stop it for anything. Malcolm Walker, who's a cardiologist in London, tells the story of admitting a patient with a ventricular tachyarrhythmia, and he gets to the patient woman gets to a cardiac ICU, and they call him several hours later to say the rhythm has come back, the ventricular tachycardia has come back. He went up to the cardiac ICU to find out that the nursing staff had discontinued the continuous infusion of desferal for 30 minutes to give another medication. As soon as they restarted the desferal, the arrhythmia went away. So again, don't think of chelation as a long-term thing that you don't do in the acute management of heart failure and arrhythmia. So this plot is looking at NTBI, and again, because especially since I see some thalassemia docs on here, I'm going to use this as the equivalent word to toxic ferrous iron. That's actually technically not completely true. But nonetheless, if you get rid of NTBI, non-transferrin bound iron, you get rid of the toxic iron as well. And you can see in the red line here, this is desferoxamine infusion starting in the blue line. And you see as soon as the desferal levels go up, the NTBI levels drop to 0. And as long as there's circulating chelator up here, the toxic form of iron is 0, and as soon as the chelator is stopped, the toxic form of iron comes back up. So the ferrous iron related to NTBI is entering the heart through calcium channels, and it's causing the problems we just talked about. So the key thing for treating this problem is start desferal immediately, and then get deferoprone, which is really the best drug for cardiac issues, started, and increase the dose rapidly. Many of these patients can be adrenal insufficient, as I mentioned, so I don't care what their previous testing is, in my opinion, and there's actually this, it says this in the guidelines as well. Stress dose them with hydrocortisone, assume that they are renal or adrenal insufficient, and then get their hemoglobin up over 10, but you need, obviously, if they're in heart failure, you need to do this cautiously. Generally, with this iron-induced heart failure, you need to avoid inotropes and avoid permanent pacemakers because we need to do MRIs to follow them. And then you need to find a cardiologist who has experience with iron cardiomyopathy, and these people are very few. I've never talked to an adult cardiologist who's even heard of buterafrone or managed one of these patients. So I would recommend that you contact one of the Thalassemia Center directors. This is the Cooley's Anemia website that has a list of all the names. And that one of the directors of one of the Thalassemia centers probably has a cardiologist that they know on speed dial. I know I do in Los Angeles, because you need to have a thalassemia cardiologist speaking directly to your cardiologist to help to manage this. Because at this point, when you're getting the arrhythmias, at least personally, I have to say, I'm out of my wheelhouse then, and I need the help. And so, this is really critical. The management of iron cardiomyopathy is not like cardiomyopathy from other reasons. Again, along the same line, this is the paper that has the guidelines on how to do this if you want to read about it. It's kind of a long paper, but all of the critical information is in there. The other thing, though, to be aware of is there are other things besides iron that can cause heart failure, and particularly heart failure with preserved ejection fraction, or HFpEF. And so particularly our patients are now living much longer, and exposure to chronic iron anemia causes myocardial fibrosis, and they get diastolic dysfunction. So the heart can contract, but it can't relax. And of course, there's not good treatment for this. And of course, this occurs in combination, with the iron problems I just described. So you do need cardiologists to help. But again, getting the hemoglobin up over 10 to 12 grams is really important. I've got a 65-year-old kid that I've been following for years, and I couldn't get his adult providers to keep his hemoglobin over 7 or 8. And just last year, I got a call from John Wood, who's the cardiologist that I work with at Children's, to tell me that in the routine screening MRI, he had substantial heart failure. This patient never had any iron in his heart, but was constantly exposed to chronic anemia. We got him on transfusions, got his hemoglobin up to 12, and within about a month and a half, his ejection fraction had come up to 40%. So the anemia is a problem in these patients with heart failure. So again, along the same lines in cardiology, just to point out that these patients can get pulmonary hypertension, and they present like anybody with pulmonary hypertension. One thing that is different in thalassemia, though, there's a lot of misunderstanding of pulmonary hypertension, that people think because your ejection fraction, your TR jet is high on echo, that you have pulmonary hypertension. The incidence of true catheter-proven precapillary pulmonary hypertension is not that high in patients with thalassemia. And again, getting their hemoglobin up to 10 or 12, a lot of the patients will improve and normalize with just that alone. So again, something to remember about the effects of anemia. We had one patient who was on a study for bosentan and had catheter-proven pulmonary hypertension. We got her on transfusions, and within about 2 weeks, everything normalized by heart cath. So again, not always pulmonary hypertension, true pulmonary hypertension does occur, but the anemia is an issue. Pulmonary embolism and deep vein thrombosis are much more common than in the normal population in patients with thalassemia, because they are hypercoagulable especially if they've been splenectomized. And then I just want to mention for a second pseudohypoxia. This is very interesting. There's not in the general thalassemias that we think of most of the time, beta thal major, but there are rare hemoglobinopathies and hemoglobinopathies that occur in combination with beta thal mutations, in particular some mutations like hemoglobin Hammersmith that have very different oxyhemoglobin saturation curves and can have very different oxyhemoglobin absorbance spectrum. So the pulse ox you use in the emergency room looks at oxygen at between 577 nanometers and 620, and it compares it to a non-oxygen sensitive wavelength at 800 nanometers. Hemoglobin Cologne and Chevrolet, and Hammersmith have a different absorbance wavelength. And so what happens is patients will look great, but their pulse ox will be 85. So the tip off is if you have a patient that looks much better than their pulse ox, and they're coming from the heme service, you need to think about this and you need to get a blood gas, because they may have a pulse ox of 85 and their blood gas will show their PO2 is 95 to 100. This is really true with hemoglobin Hammersmith. But again, these are really rare syndromes. So anemia is something that you're going to see in the patients in the emergency room. Generally, the transfusion-dependent patients are transfused every 3 weeks. But depending upon whether they get a good unit or a bad unit or not much blood or the previous time, their hemoglobin can be quite low, and this can cause a lot of symptoms, and the symptoms are related to the rate of drop. So their hemoglobin tends to drop much faster in the week before their transfusion is due, and this can make them quite symptomatic. And so transfusion can fix that. They can have severe bone pain because the suppression from their transfusions goes away. Many patients will complain of back pain in the 2 or 3 days prior to their transfusions. And in the presence of viral infections, again, they can have splenomegaly, which can cause their hemoglobin to drop more rapidly. So again, a lot of symptoms that can be related to worsening or rapid worsening of anemia, especially in patients that are used to having hemoglobin in the 10 to 11 range, and for whatever reason drops down into the 6 or 7 range. They can have a lot of symptoms and they show up in the ER. Similarly, non-transfusion dependent patients can get into the same trouble. Their hemoglobins are usually between 8 and 11. Hopefully not as low as 8, because we don't like to have them that low, but nonetheless, they're not on regular transfusions, but again, their marrow can get shut off, particularly with parvovirus or with any viral infection at all, and they may wind up having the hemoglobin drop from 10 down to 8 or 10 down to 6. Because their red cell survival is short and they can't make red cells very normal, make red cells normally. But these patients, if you don't transfuse them, either way, it's important to follow up a week or so later or even sooner to make sure that their hemoglobin is stable and isn't continuing to go down. A lot of times when we think of hemolysis, we follow the reticulocyte counts. It's important to remember reticulocyte counts are not very helpful in thalassemia because of the maturation arrest that I talked about. So unlike sickle cell disease, for example, the retic count may not help you. Pain is another thing that you have to deal with in thalassemia patients. Now, in general, thalassemia does not cause pain. So patients that are well transfused, their hemoglobins have been maintained at a good range. They don't have osteoporosis and they don't have extramedullary hematopoiesis. The disease itself doesn't cause pain, but a lot of patients with thalassemia have pain. We'll talk a little bit about that in a second. The differential diagnosis for acute chest pain in a thalassemia patient is the same as it is for any normal population. And particularly important to remember this because the patients are living longer. But pulmonary hypertension and pulmonary embolism are something you always need to think about because the incidence may be higher. We already talked about osteoporosis. If they're not well transfused, they can have significant osteoporosis, and I've seen patients with T-scores on DEXA scan of -4 when they're 25 years old. So when you see a 20-year-old patient complaining of severe back pain or bone pain, they very well could have severe osteoporosis and have fractures or just pain associated with this. So again, severe osteoporosis in young people is something that we can definitely see. We already talked about the anemia from marrow expansion, especially severe back pain in these patients when they become anemic. If they're having radicular pain, shooting down their legs, things you would call sciatica, you need to think about the possibility that they have a bone marrow tumor pressing on a nerve root. You find this out by doing an MRI. They can have paralysis and weakness as well. So, neurosurgery may need to evaluate them. Low dose radiation is effective. They may not need surgery, but again, you establish the diagnosis of impingement of the nerve, and neurosurgeons can guide you on what you need to do, but you need to talk to the hematologist for sure. Interestingly, this is not a common thing, but we need to think about it. The patients that are on chronic transfusions can have acute citrate toxicity. We've seen excruciating pain, particularly in the arm where the blood transfusion is being given. And this is due to the fact that the anticoagulants chelate calcium, and they get a severe neuropathic pain. And this can really, if the patient already has neuropathic pain, this can really exacerbate their existing pain. The treatment is to infuse calcium gluconate at the same site where the blood is going in. And that can take care of it. Again, rare, but rare complication, but at least something to think about, citrate toxicity from transfusion. Gallstones are common in these patients. It's the same as any other patient's presentation. Kidney stones are a little bit more common, particularly if they're on Cirox, because this causes tubular damage and increased calcium excretion. Deep vein thrombosis and pulmonary embolism, we already talked about, a little bit more common. Infection with Yersinia. This organism doesn't necessarily cause fluoride diarrhea. It can cause sepsis and can cause full-on sepsis and diarrhea, but it can also mimic appendicitis. And again, something to think about. It can have diffuse abdominal pain, appendicitis-like symptoms to the Yersinia, and it's treatable with appropriate antibiotics. We'll talk about this in a second when we talk about the chelators, but the chelator deferriprone can cause severe joint pain and even significant arthritis. Again, this can be treated with NSAIDs, and you need to talk with their hematologist about this management. Luspatercept it's a medication that's injected every 3 weeks to try to raise the hemoglobin level. This can cause very severe pain, bone pain, usually only at the beginning of a treatment, but they may show up in the emergency room because somebody started this medication. Interestingly, Claritin and NSAIDs given the night before you give the injection for a few days can be very helpful in managing this. It's more of a problem for the hematologist than the ER, but you could wind up with a patient who just got their luspatercept injection yesterday and now they're miserable. Again, myofascial pain, chronic regional pain syndrome. These patients, when they're older, can have a lot of bone pain, and they can get into myofascial pain and neuropathic pain syndromes, really triggered by their chronic bone pain. So again, I'm sure that you see in the ER lots of patients with this kind of pain. The treatment is no different in thalassemia than it is in patient. Scurvy. I mentioned this just because we had a recent case in a 25-year-old patient. We couldn't figure out what was going on, and he had classical vitamin C deficiency. Especially the older patients are told not to take vitamin C because high-dose vitamin C in the face of iron cardiomyopathy has been reported to cause actually death in some patients. This is a little bit of black pearl that's circulating in the thal community. Patients need vitamin C. And I've seen several case reports and heard a few presentations at meetings in thalassemia about scurvy, which can cause severe muscle pain, bruising, and bone disease. So I don't want to put this up as a common thing, but something just to keep in the back of your head. I don't know if it's more common in thalassemia or not, but it's certainly not hasn't been common in my practice. But it led us on a wild goose chase for several weeks before we fell to the diagnosis. Fever in the emergency room with thalassemia. Again, thalassemia is not an inherent immune deficiency syndrome. There are measured immune deficiencies that people have seen, but how much of a big deal this is in terms of patients getting infected, it's not really clear. They may have been surgically splenectomized. We're doing this less than we did before, but they are at risk for all the complications of splenectomy, including encapsulated organism sepsis. We tell our splenectomized patients to go to the emergency room immediately if you have a high fever, to get worked up and to get parenteral antibiotics. Also importantly, the chelator deferoprone, which the patients may be on, causes agranulocytosis in 1.5% of the patients. So we tell the patients on deferoprone, if they have a fever, they need to go to the emergency room. They should tell the ER doctor on a drug that causes agran. They need to get a CBC done in blood cultures. If they have low white count, they need to be treated like any fever and neutropenia patient. And there have been deaths because of this, particularly when the drug wasn't discontinued in the case of severe neutropenia. We already talked about Yersinia, so I won't talk about it again. And always remember, a lot of the thalassemia patients have indwelling catheters and so forth, and so these can get infected. And I'm sure that in the ER you see a lot of these patients. Let's end up by saying a few things about chelators, because chelator toxicity you may see in the ER. And just as a general comment for ER docs, if you suspect the chelator is involved in the symptoms, there's no reason that you can't stop the chelator for a few days until the patients can get a hold of their hematologist. The only exception to this is if the patient is early in the treatment of iron cardiomyopathy and has arrhythmias and stuff, then it could be a problem, but that's rare. Normally, stopping a chelator for a few days, even a few longer than that, isn't a problem. You should know that iron overload itself elevates the transaminases from 40 to 100, but usually not over 250. And the chelators can also cause a transient elevation in the transaminases, but usually not dramatically. Indirect bilirubin is usually elevated, often elevated in thalassemia patients, but not dramatically so. But the direct bili is not. And the chelators do not cause the increase in the bilirubin with under standard use. Deferoprone is an oral chelator that they take every 8 or 12 hours. There's two forms of it. There's a long acting form and a short acting form. It's important to know that this causes the urine to turn red. So sometimes we forget to tell the patients this, but that's the drug coming out of the urine. This medication is not necrotoxic. The main thing I already talked about with deferoprone is that it can cause agranulocytosis. And so you need to check the CBC if they're febrile and they are on this drug and act accordingly. Deferoprone can also cause joint pain, significant joint pain, and in fact, swelling of the hands and frank arthritis, and this can be dose limiting. You can treat it with NSAIDs and pain meds in the ER, but this is really a problem that's going to need to be managed by the patient's hematologist. The Ferrocirox is very commonly used oral chelator. The package insert says it can be given once every 24 hours. We usually use it differently twice a day, but which is not what the package insert says. But regardless, it has a long half-life. The toxicity of this is dose related, and it seems to be worse generally when the total body iron concentrations are in the lower end. Well, this is unlike deferoprone that we just talked about. There, the toxicities are not dose related. Well, at least the neutropenia is not. It's totally idiosyncratic. With the ferrocirox, the dose is important. About 30% of these patients will have a 30% rise in their creatinine. And the hematologists are following this very, very carefully. But the drug can cause renal Fanconi's syndrome, acidosis, high potassium. They're having deaths because of this. And it also can cause very severe hypertension. So I've had patients with actually malignant hypertension who were, one in particular who was placed back on the drug after I had decreased it. Placed back on the drug by his local hematologist after we had decreased it because his iron level was very low. So generally, when monitored, the drug is very safe and it's effective for the management of iron overload. But you really need to watch the kidney function very, very carefully. It's also been associated with gastrointestinal hemorrhage, particularly in adults. And again, this is more common when the iron is low. And it can also, a subset of these patients have significant gastritis and esophagitis, cramps and diarrhea and abdominal pain associated with this. Again, it may show up in the ER with this, but generally this is going to be managed by the hematologist. And then lastly, not used very often, but deferoxamine is a continuous, given by continuous intravenous or subcutaneous infusion. Again, not used all that much, but it is still used. And the main really emergency thing that can happen with deferoxamine is anaphylaxis. And one of the problems where we've seen this is that allergic reactions are more common with this medication. And we used to try to desensitize patients to deferoxamine. And then the patient stops taking the deferoxamine, loses their desensitization, then starts taking it again. And then they come to the ER with anaphylaxis. So that's the main serious life-threatening thing that can happen. Otherwise, they can get swelling and pain, and even infection at the site of subcutaneous infusion, and local measures are what can be used. And occasionally, people try to use very high doses of this medication. This can cause acute respiratory failure. But probably you're not going to see much trouble with this at all. This also, by the way, causes the urinary tract. So I think that's all that I have. I tried to just give a brief listing of the things that may be a little bit different in the thalassemia patient when you see them in the emergency room. I'm sure I forgot a few of these things, but some of the other folks in the audience can speak up and point those out. So thank you for your attention.
And it looks to me like Sharif has a question. Go ahead, Sharif.
Yeah, terrific talk, Tom. I really kind of enjoyed how comprehensive you were in looking at different symptoms and complaints that patients can come to the emergency room with. It kind of made me think about how this can be even more in action broadly, right? For sickle cell pain, for example, patients always have their pain action plan, right? And they actually sometimes can go to the emergency room with that. What kind of opioids work for them, what's their dose, what's the thing that they need to kind of maybe use for the ED, because again, not everybody sees the same patient and they can see care in different places. It depends if they're traveling or not the main center. So it just made me think, I love again how comprehensive it was, and can we take it to a different level and making it more of a card with the main things, but maybe then there can be a QR code that people can actually go back to a more deep dive into specific actions that are related to the specific patient, right? What chelation they're on, what kind of past medical history relevant for them, to just make it maybe more customized, for this given patient. And it definitely can be more, integrated, right? Rather than just being a simple card in an app or whatever. I know you like to work on apps as well, as so do I. So I don't know if you can just comment on that thought.
No, I think it's a great idea, and it would be a great thing to work with coolies on, because
Absolutely.
because I think they have some through the HRSA grant, they put out some really nice guidelines, and the topic of pain, I have to say, this was looked at, and it wasn't by the doctors, it was by the nurses, by Drew and Sue and Carson and Murray Martin. Sort of brought all this to our attention many years ago, that pain actually is a little bit neglected thing by the thalassemia docs, and especially if they have chronic regional pain and those kinds of issues, it could be very important to have have something like that. So I think I would support that. I think it's a great idea.